Hello everyone. Today we are going to study the topic of extraaxial hemorrhages. It is of two types, epidural hematomas and subdural hematomas. In previous lecture, we studied about epidural hematomas. Today we will study in detail about subdural hematoma. Subdural hematoma is collection of blood between the dura mater and the arachnoid mater in the subdural space. It is of three types: acute, subacute, chronic or mixed type. We will study each of them in detail. Acute subdural hematomas. Trauma is the most common cause of acute subdural hematomas. Especially in elderly patients who are often on anticoagulation, even a relatively minor head trauma may result in an acute STH. In such patients, a definitive history of trauma may be lacking. The basic pathology lies in tearing of bridging cortical veins as they cross the subdural space to enter into the dural venous sinuses. The most common location is cerebral convexities, but a large STH may spread along the tentorium. So, in 95% of the cases, it can be supratentorial, and in 15% of the cases, it can also be bilateral. It is usually a crescent shaped collection which is not limited by sutures, but generally it do not cross the dural attachments. In order to detect a small subdural hematomas, we should always adjust our window to subdural window, that is about 150 to 200 Hounsfield. In this image, we can clearly see that after adjusting our window, we can easily detect a small hyperdense collection along the cerebral convexity, which is a subdural hematoma. On CT, subdural hematomas, they can be either hyperdense in 60% of the cases, mixed in 40% of the cases, and it can also be isodense. In this axial scan, we can see a hyperdense collection along the cerebral convexities, which is seen crossing the suture line, but it does not cross the dural venous attachment. Also, supratentorial spread could be appreciated, but this supratentorial spread is well appreciated on coronal images. In this image, we can easily see supratentorial spread. So, occasionally, the acute subdural hemorrhage can also be mixed. In this image, after a 6-hour interval scan, we can see the isodense unclotted blood and the hyperdense clotted blood. So basically, this was an anticoagulated patient with a mixed density actively bleeding acute STH. In anemic patients, acute STH can also be isodense. In this image, we can see an isodense collection along the cerebral convexities, which is seen crossing the suture line but not the dural venous attachment, and is displacing the gray-white matter junction inwards. This is an isodense acute STH. Now, what are the indications of decompression? In EDH, we studied the formula of 15 into 2, 30 divided by 5. That is 15 mm maximum thickness, 30 mm maximal volume, and 5 mm midline shift. In SDH, the formula that we need to remember is 2 and 3. 2 centimeters and 3 mm. So this is basically that the diameter of subdural hematoma should be more than 2 centimeters and the midline shift should be more than 3 mm the thickness of STH, that is 20 mm plus 3 mm. If the midline shift here is 23 mm or more, then it will be considered as significant. So then this will become the indication for decompression. So the numbers that we need to remember in EDH are 15, 30 and 5, and in SDH are 2 centimeters and 3 mm. Now we will have a look at subacute subdural hematomas. Basically, subdural hematomas, they will undergo organization, lysis and neomembrane formation with time. So we will see an inner thin and a thick outer membrane. This basically represents formation of granulation tissue with time, and inset also shows the bridging cortical veins. The imaging findings, they will be related to the hematoma age. Basically, the most important thing that we need to know that SDH, they decrease about 1.5 Hounsfields per day. So in 7 to 10 days, they become almost isodense, and by 10 days, they become hypodense. In the above image, we can also see the CSF dot sign under the SDH. This is a common finding in subacute SDH. In this image, we can see isodense collection along the cerebral convexity, seen displacing the gray-white matter junction inwards, crossing the suture line, but not crossing the dural venous attachments. This is a subacute subdural hematoma. On MR, again the signal will vary according to the clot age. Now we will study about chronic or mixed subdural hematomas. Basically, organization and resorption of hematoma contained within the membranes of surrounding granulation tissue will continue, and these neomembranes, they are very fragile and they can be easily disrupted. So there is a high risk of rebleed, which will create a mixed subdural hematoma. Generally, chronic SDH is of two types, a simple chronic SDH and a complicated chronic SDH. In simple chronic SDH, it contains a syringeous fluid which is surrounded by a thin inner and a thick outer encapsulating membrane, and a hematocrit effect can be seen, that is, the new blood settled at the bottom and the old blood layered at the top. In complicated chronic subdural hematomas, we can see loculated pockets of old and new blood, which is seen as fluid levels within the septated cavities. Now we will take a look at CT scan. This is the CT scan of a simple chronic subdural hemorrhage. We can see a hypodense collection along the cerebral convexities. And this is mixed chronic subdural hemorrhage that features multiple loculated pockets of blood with old blood layered at the top of the recent hemorrhage. And these membranes, they generally show increased risk of rebleed. This is often known as Parfait effect, and this can be better appreciated on MRI. With age, even these encapsulating membranes, they become thickened and can appear relatively hyperdense. So some of the chronic subdural hematomas, they will show peripheral calcification, which may persist for years, and this is termed as armored brain. Now there are few differential diagnoses of uncomplicated chronic SDH. It is subdural hygroma, that in case of arachnoid tear, when the CSF gets accumulated in subdural space, as it is shown in this image. It is almost impossible to distinguish it from SDH. A subdural effusion, when the clear fluid accumulates in subdural space after inflammatory process like meningitis, and a subdural empyema. So this was a short video on subdural hemorrhages. Thank you.